My name is Siobhan Reynolds, and I'm standing in for your usual Talk Time host, Roisin Breen. And today, myself and Noemi from the National Quality Improvement Team are looking after Talk Time today. This is our 5th Talk Time since September, and I'm delighted to introduce an initiative from Cheeverstown Services supported by the HSE Spark programme. The title of today's webinar is Stop and Watch, an early warning tool for recognising deterioration. And we're joined today by Sandra O'Reilly and Ailish Mooney, members of the Cheeverstown team, and also by Dr. Alan Hopkins from the HSE Spark programme. The Spark programme, for those of you maybe who don't know, is an NCHD-led initiative and that encourages healthcare providers to develop and implement their ideas so that we can improve our health services. It's been in place since 2017, and applications for seed funding for individuals and for group projects can be put forward. Funding is awarded on a once-off basis, and you're going to hear a little bit from Alan with regard to that. And then also, I suppose, in relation to Cheeverstown Services, you might be aware of Cheeverstown House. It's a voluntary organisation providing a wide range of residential, respite and day services to almost 400 children and adults with intellectual disabilities. So before we hear from Alan, Sandra and Ailish, we have a number of housekeeping items that I want to remind you of. So if you wouldn't mind, Sandra, just rolling on the slides there, and we'll just run through some of the housekeeping items. So the dial-in number today is 526-0058. The event number is 174-587-6860. And you can use your computer or phone to dial in for audio. And some people find the phone is better than the computer. We have our chat box active, so please do feel free to add in your questions and comments and select everyone so that we can all see those. And what we'll do is we'll take the questions at the end of the presentation, if that's okay. But we want to make this as interactive as possible. So please feel free to add in your questions and comments. Also, we'll be recording this QI Talk Time and we'll make the slides available. So thanks very much. So without further ado, I'll hand over to Sandra, Ailish and Alan. Thank you.
Oh, yes. Well, good afternoon, everybody. How are you? How are you doing? Listen, just to thank everybody, you're very welcome to join us here in Cheeverstown House for our presentation today. We're very excited about sharing the work that we've done on this quality initiative. And just to introduce the people that are in the room today with me, we've Dr. Ailish Mooney, who's here beside me, and she's a senior clinical psychologist. We've Maria Fitzpatrick, who's a CNS, and we've Fiona Shannon, who's a CNM3 as well. But just to start our presentation, we wish to acknowledge, I suppose, the exposure that we got to the Spark Innovation Project was a real influencer for us to develop this quality initiative. So with that, we want to invite Alan Hopkins to speak about the programme a little bit more, and we're delighted that he's here today to support us with this as well. So thank you.
Hi, how are you doing? Thanks very much, Sandra, and thanks everyone for the opportunity to talk today. I'll only say a quick few words and then get back to Sandra and the guys to talk about their project. Alan Hopkins is my name. I'm one of two innovation fellows that Emily Mahan as well works alongside me. As Siobhan was saying, we're in our 4th year now. It was initially just NCHD led and for NCHDs, but it's grown. So the nurses and midwives got involved last year, and just recently the HSCPs have become involved too. So I suppose the goal and the aim of the programme now has become to support all healthcare workers who might have an innovative idea to make it a reality if possible. So to talk more specifically about Sandra and her group, they were selected from applications in seed funding and to come along to one of the workshops. But at that time, COVID kind of just kicked in. So they presented to us digitally at one of our virtual workshops. And the way the workshops work is they get a lot of design teaching from Trevor Vaugh. And then at the end of the day, they have the opportunity to pitch their idea. And it was in that area that we really saw the brilliance of this project. Sandra spoke fantastically about it on behalf of her group. And we could see the passion that she had for the project, and also that she had a great understanding of the project and was definitely going to be driven to achieve at the back of it. So I suppose we think they're doing fantastically, given that COVID has been going on, to see the amount of work they've already done and how much they've already achieved. It would be great to see similar projects brought in other centres around the country, because I think it's already doing good and it continues to do more good as well. So just back to the Spark program again, we recently had our COVID call and we had an overwhelming response to that, far more than we'd ever usually get. And we're going through them at the moment, and we're going to do multiple stages this time of bringing people in. But if anyone's listening who has an innovative idea, we do Spark Ignite, which will be early next year, and then we'll be doing more calls as well. So watch out for us on Twitter and online. And now I'll hand you back to Sandra and the guys to tell you about their fantastic project. Thanks very much.
Thanks a million, Alan. That's a very positive feedback, so we really appreciate that, actually, so thanks a million. So I suppose just to look back on the background really to the initiative, as we said, the exposure to the Spark Innovation Programme really started getting us to look at what we could do at the start of 2020 in relation to quality initiatives. So what we did is we kind of set about looking at our training needs and did an analysis on that. And I suppose through conversations with our Head of Operations here, Denise Fahy, and also Deirdre Halford in TUH, myself and Fiona Shannon here kind of came up with the topic of recognising the deterioration in the person with intellectual disability, because we acknowledged that there was an absolute gap here for us in Cheeverstown. So ironically, to think back, that this is what we actually decided on, not realising 2 months down the line what the national picture would look like. So we were delighted that we did actually at the time put effort into this work. So we did about a search on the research, and I suppose what we did come up with was the fact that the research wasn't really very positive, because what it did show was there was absolute a lack of, we'll say, tools out there to support, we'll say, care staff and social care staff in particular within the social care model to look at recognising deterioration. So we kind of identified that as well. But what we did come across, which we were so lucky, was a ready-made tool which was devised in North Cumbria, and it was called Stop and Watch. So we'll just move on to exactly what that tool is. So I suppose the Stop and Watch tool is an early warning communication tool which can be utilised, sorry, that screen is there, sorry for just 1 minute. Yeah, it can be utilised by certified healthcare assistants or social care workers to alert a nurse or manager if they notice something different in the person's daily routine. Okay, and just to say, the origin of the tool, as we said, it comes from North Cumbria. And if you see the lady down the very bottom of the screen there, that lady's name is Anne Stabler, and she's the lead on the project in North Cumbria. And basically, they were very, very helpful to us when we contacted them, and they gave us permission and access to use the tool, which we were absolutely delighted. So the origin of the tool for them was developed in response to local learning reviews that highlighted circumstances where vulnerable patients could have been helped to seek medical assistance sooner. And I suppose really an important note for us was they highlighted the need for it, particularly noted in patients with learning disabilities, as the characteristics and symptoms associated with the learning disability potentially mask symptoms of other underlying health problems, meaning that they might go undiagnosed and lead to more serious health issues. Okay, so how does the tool work? So the tool is very, very simple. So it's a presentation of the 12 signs of deterioration as a simple abbreviation to help people to remember them. And there's a little picture down the end of the little Z card booklet that comes as a tool. It comes in a printed leaflet format. Carers and family members are able to keep this with them as an aid in memoir. And it can be used as a reference point to check any concerns the person has. And also a space for notes at the back to make sure that we can communicate those changes to health professionals. So this is just a little bit of the picture of what that tool looks like, and this is what we found was most brilliant, because it was so, it looked like it was just so easy to use, because obviously with the emojis, everybody is used to using emojis at the minute, either on social media or on your phones, you know, people can relate to them. So it wasn't a tool that people would be afraid to use. So every letter is related to a sign of deterioration. And also on this card as well, you'll see it has the Bristol stool chart, and it also has a hydration chart. And at the back of it then has the early warning tool, which is just somewhere where people can record their concerns. So that's what we really thought, that the emojis were very eye-catching and really appealing. We say to people how they would actually find it very easy to use this tool. So we're just going to show you now a short clip of what we also used to support staff, I suppose, to understand the really important changes that they need to be aware of, and especially, you know, in conjunction with the tools that we're using. So Ailish is here helping me, my IT person. Okay. So just if you can bear with us for a minute, and we'll show you this little video, because it really, really is really helpful in trying to identify exactly the changes that we think, you know, care staff and social care staff should be aware of. So if you just bear with us here now, we're just there now. Okay.
Oh, hold on. I opened up the wrong thing.
It's okay.
Give me 1 second. Sorry, tech.
And here we go.
No, not just.
Okay.
Almost though. No, it should be ready to share now.
Okay. Sorry, everybody, just bear with us for 1 minute.
Sorry.
Yeah.
I'm just going to share it the other way. Apologies. This worked, of course, in
the trial
run, and then you come to the real thing.
Yeah, sure. Listen, we're okay.
Would you like me to share it from here?
I just have it open now, I think.
Yeah, we're good to go. Yeah. Thanks a million, Siobhan.
Thanks a lot. Great.
Now we'll just pop back to share the screen.
Great. Okay, thanks, Ailish, for my IT support here today. So I suppose with that video, we felt that video was fantastic because it was so simple. And it just basically gives, you know, the essence of what we want people to realise and, you know, recognising the change. And also, I suppose this tool is designed for staff to go with their gut feeling. because I suppose we're very lucky here in Cheeverstown. We have staff that have worked and supported people here for a long, long time, and they know our services so well. And I suppose before this, they may not have had a platform or a process to engage in to bring those, changes that they might have seen, be it a small change. So now we're happy that we're supporting staff to do that, and we're very much emphasising that they are the important people on the front line who are observing and monitoring people every day and bringing that really vital information then to their line managers and passing it all up. So I think that video was really, really good. It really hits home with staff as well. So I suppose we've answered a little bit there before, but can carers spot the signs? So I suppose it's pretty important that we look at the research and say, can they, or do a bit of work around that. And absolutely, yes, they can. And I suppose one study in 2000 showed that nursing assistants in a care home spotted signs of illness in people 5 days before they were seen in observation. And the study found that nursing assistants were able to spot behavioural and functional state changes in residents. And I suppose this is what we bring this information when we're doing our training to staff, to empower them, to know that they can actually spot these changes and they can make an absolute difference. So what I'm going to do now is I'm going to pass on to Ailish just to see the importance of this tool for people with intellectual disabilities.
Thanks, Sandra. Sorry, the joys of COVID, we're all moving our individual chairs and masks on and off and all of that. So I just wanted to talk a little bit about why is a tool like this important. So I suppose tools like this have been around in care of the older person for a while, but in intellectual disabilities, often we're kind of, I suppose, the end of the line in terms of implementing some of these tools. They often are implemented in mainstream services first. So why is it important for people with intellectual disabilities? And really, when we look at people's health outcomes with who have intellectual disabilities, we notice that there's a significant disparity between people with ID and people in the general population. That's both in their physical and mental health. People with intellectual disabilities generally have very poor access to healthcare. So often you need evidence, significant evidence of deterioration for medical appointments. And something as simple as, somebody has a UTI, but also has a diagnosis of severe intellectual disability, autism, and dementia. It's very hard to pick up what's what. So you may be experiencing delirium as well as dementia. And what is delirium? What's dementia? How do you unpick them? So usually it can be quite difficult to pick up on what is one symptom over another, and getting access to the appropriate healthcare can be challenging. So other things then you have to think about in terms of the person's presentation is communication deficits. So many people with intellectual disabilities have difficulty communicating their needs. Many people with severe to profound intellectual disabilities would have very, very limited verbal communication in general. Some would have almost no verbal communication. Some communicate gesturally or through sounds, noises. Some have some language. And even for those people who have a lot of language, who would be able to say, I am in pain or I feel sick, they might find it really challenging to identify the source of that pain or the source of illness. So often we find people use the same gesture for I feel sick or I'm in pain. So it might be rubbing their tummy, but that might mean that they've stubbed their toe and broken it. It doesn't necessarily mean that the pain is in their tummy. So our staff really struggle to identify the source of pain and to actually really determine what is wrong with the person, why are they off. So pain and illness are often significantly overlooked and misattributed to behavioural difficulties. So often one of the main signs that somebody is not feeling well is a change in behaviour. So that might be withdrawal, it might be an increase in self-injurious behaviour, it might mean a change in their vocalization or increased pacing. And often that's kind of attributed to kind of mental health or distress or, so-called behavioural difficulties, that I'll put in brackets there. So often that form of communication of there's something wrong with me is misinterpreted. And it can be quite challenging to get the actual real message of someone. You really have to know somebody really well in order to interpret that appropriately. Then there's significant difficulty recognizing pain and illness and identifying the source of it. And as I said, that's particularly common in people with autism. So we have a high kind of percentage of people with autism in disability services, in particular in residential disability services. And it's one of the attributes of autism is often a very high pain threshold. So it might mean that somebody is in extreme pain before they're even indicating minor pain to you. There's higher rates of certain illnesses and conditions, and I'm going to talk about that in more detail in the next couple of slides. And there's a really high rate of staff turnover in intellectual disability services. Well, really in all residential services, I suppose the same could be said in nursing homes. But that can mean that because you've such a high rate of staff turnover, you really need a standardized tool, something that each person understands how to use so that you can monitor somebody's symptoms over time. So when we look in more detail then at health outcomes for people with intellectual disabilities, there's a significantly increased risk of early death. And this, is quite stark, actually, the research in this area. Compared to the general population, the life expectancy of people with intellectual disabilities is significantly lower. Now, it is improving, and with improved medical care and improved access to medical care, improved understanding of people's communication of illness, those things are changing. But it is slow to change, and there is still a significant disparity. And then, in particular, people with Down syndrome have an even lower life expectancy. That's often related to the development of dementia in the person's 50s, kind of 60s level. But again, it is improving over time, but it is often difficult to recognise some of the illnesses and difficulties people are having. The most common causes of mortality in people with intellectual disabilities are circulatory diseases, respiratory diseases, neoplasm, and nervous system diseases. So when you're looking there, obviously respiratory diseases being second. In the current climate, there's a huge rate of people with intellectual disabilities with compromised respiratory systems. So COVID was a real worry. I mean, you're talking early March, people were really anxious because we have such a high rate of vulnerable people in our service. So disability services really went into overdrive in terms of how are we going to protect these people and how are we going to recognise illness early enough to be able to prevent the spread and prevent deterioration. So I think some of the work that Sandra and her colleagues had started just before this was really invaluable in terms of identifying deterioration in the early stages of COVID, especially when our anxieties were so high. And just from kind of a psychological perspective, organizational anxiety went through the roof in March, and people really struggled. And having a tool that had a very clear path and very clear system in place really allowed people's anxieties to settle and kind of fall back into the rhythm of working, which I think was a really invaluable timing. Not the timing we probably would planned, but it did actually work out to our advantage. And Sandra's going to go through our kind of COVID journey later on in this presentation. And then kind of lastly for me, we've had an amazing research study done in Ireland, IES Tilda, which was related to an ageing study, and Mary McLaren led out the intellectual disability part of that study, which gave us a phenomenal amount of information on how people with disabilities age and what comes up for them in terms of physical difficulties. So just for stats and just for general information about why recognising signs of deterioration is so important, there are significantly higher rates of osteoporosis than the general population. So 42% of people with intellectual disabilities will develop osteoporosis at some point in their life. Significantly higher rates of constipation, 48.8% in women and 36.8% in men. Very high rates of falls. 27% of kind of falls with 12.5% sustaining injury. And then don't forget that you have to link that in with the higher rate of osteoporosis. So higher rates of falls plus weakened bones results in higher rates of fractures. A significantly higher rate of dental issues for people with intellectual disabilities, and that's for a range of reasons: difficulty accessing dental care, difficulty completing oral hygiene, difficulty with nutrition and hydration. Like, there's a huge range of issues that contribute to that. But 28.3% of people with disabilities reported that they had no teeth, with almost none of them offered replacement dentures. So there's an extremely high rate of people with very, very poor oral care. Very high rates of eye disease, 15.9% of people with cataracts, with even higher rate in the Down syndrome population. Sorry, DS is an acronym for Down syndrome, and often develop them much younger than the general population. Dementia rates are very high, in particular in the Down syndrome population. Again, there's a high rate of diabetes and a significantly higher rate of epilepsy. And to be honest, the list could go on and on and on. Some of the research is suggesting higher rates of gastro cancers. Some of the research suggests higher rates of migraine. It's kind of understanding illness in disability takes a higher level of understanding of the person than in the general population. And again, that goes back to all of the things I've spoken about earlier. So I'm going to hand back to Sandra to discuss the aims of implementing Stop and Watch, and then I'm going to pop back on later to wrap up. And then if you have any questions about what we've talked about, I'm happy to answer them at the end of the presentation.
Okay. Thank you, Eilish. That was really very interesting. I suppose we're still pre-COVID here for this slide, I suppose, so it's the aims of implementing the Stop and Watch. So what were we planning before COVID hit, I suppose? So I suppose the main important thing is, as Eilish would have said, is to facilitate the detection of the deteriorating service users, and particularly in the earlier, more timely medical review of service users. For us, really important, I suppose, strategically, disability services are looking at, full decongregation. So we need to be able to guide care staff and our social care worker, through brief reviews of early changes in their service users' presentations. So it's really, really important that we can give people those supports as well. I suppose to enhance the communication between frontline staff and the nursing manager in charge, to improve the quality of care for the service user overall. And then I suppose what we really had planned was to develop interdisciplinary projects that would utilise the tools to collect data to support positive health outcomes for the people who would use our service. And we were very excited about that, setting up some projects in that area. But however, something else came, and then I suppose Ireland's first recorded case of COVID-19, February 29th, 2020. And I suppose every one of us remembers the days and the weeks that followed that. And actually going back to what Eilish said, it was a very unprecedented time, and it was, what do we do here? So I suppose the big idea was don't panic. So it was hard not to, but it was a time where we needed to get our processes in place to ensure that we had, we would say, proper supports that would support our service users to keep them as safe as possible, obviously through this very serious time. So what we did here, I suppose, in Cheeverstown to respond to that, and how we would have used the Stop and Watch to do that. Sorry, can I open that up? Okay, so how we would use the Stop and Watch to do that was that we used as part of our monitoring and escalation toolkit. So what we did was we combined the Stop and Watch toolkit with our clinical observation assessment tool to form our monitoring and escalation toolkit, and it was really very effective. And what else we did was we provided training on the ISBAR tools for communication, and we connected all of these forms of the toolkit together to the escalation protocol. Okay, so that was very good from a senior point of view. We knew what we were doing, but we needed to get this information out very quickly then to the staff on the ground, who really obviously played a really, really important part in this. So training on the tool was fast-tracked to support staff to monitor and escalate concerns as part of phase 1 COVID training. And I suppose what happened after this was that then staff started to communicate with their line managers and bring information up to our outbreak control team, which led to daily reviews for our service users. So it had a massive impact that way. But I don't think we could actually go, I suppose, go through this presentation without mentioning our nursing response team, who were absolutely amazing here during the time. And they became champions of the tool. They were the people who led the training out on this tool. They facilitated training 3 times a day and 7 days a week to support our staff. So it was absolutely phenomenal, the response and the support that everybody put in place during this time. So just to give you an idea, I suppose, how Stop and Watch fits into our processes here. So this algorithm is be suspicious in AD COVID-19, and this was devised by our COVID lead here, Anya Enright. And I suppose if you just go through the top of it, you'll see where it says Stop and Watch. And then if we work down, we see a change from the usual presentation. So there's an action from this when we see this. So there's a thorough clinical assessment done by a nurse. And then with this information, then we've got two pathways we can go. So we can go down, if you look at the left-hand side, we can go down the non-COVID pathway. Now, we're very cautious about doing this, obviously, at this time. So, we go through, we really review and see the information we have to make sure that's the pathway we should go. If not, if we are suspicious in relation to COVID, then what we do is we activate our COVID suspected care plan. And that brings in all our processes around IPC, around support for the service user, about GP referral, about risk assessment. So really, if you can see from the, at the start of this algorithm, it starts with the stop and watch or a change in the clinical observation, and the process then is followed all the way through. So it's a really, really helpful algorithm as well that we've actually given to staff at the phase 2 COVID training. So I suppose it is worth noting, I suppose, at the time of COVID, and we go back to the nursing response team, they did phenomenal work doing training on stop and watch, respiratory etiquette, mask wearing and all sorts. So it was very, very overwhelming for staff to take in all this information at the one time. And obviously there was a lot of stress for them as well. But what we really wanted to share and bring home to them was what we really need you to do is recognise change, respond to the change and communicate that change to your line manager. And really, if you are concerned, the most important thing is that you tell somebody. That was really the message we wanted to get out there. So I suppose just to look at some of the outcomes we have to date, I suppose just to say, obviously this is really in its early stages, we have a lot more work to do, but we have seen, the use of the tool and how, I suppose, effective it has been for us to date. So we've collected that, I suppose, in relation to the daily reviews of service users, and it indicated that the tool is being used. And the main symptoms reported linked to the stop and watch tool from April to July were fatigue, agitation, decreased appetite, loose stools, and overall needs more help. Now, whether these were COVID related or not, I suppose what it really is good to stress here, there was an action that came from all of these observations, okay? So whether it was for the person was a referral to the MHID or referral to the GP, or it was just an action of increased observation. But staff bringing these observations to the line manager, then to the outbreak meetings, then for review, it all had an action, okay? And that's really, really important. So I suppose the other outcome we would see then that staff, they feel validated in identifying change and escalating it and not depending on waiting for clinical signs, which that's what we want people to do. And I suppose then within the organisation itself and managers too are recognising the strength of these changes to be taken seriously, which is really, really important. So I suppose the benefits that we've seen so far, okay, in the early stages are there's an increase in staff confidence and understanding of deterioration in a social care setting, which is brilliant. As we said with the tool, you don't need to be clinically trained. You need to know the person, and that's really, really important. And listen to your gut and go with your gut. Earlier escalation to the GP, common language being used between all staff, and we've definitely seen evidence of that throughout Cheeverstown, which is brilliant. And I think it's the beauty of the essence of this tool is that it's so easy and it's so user-friendly that people are not afraid to use it. Improved communication, improved health comes due to the early reviews, and as I said, it's very easy to use. So this is the feedback. At present, we're in week 6 of COVID 2 phase training, and really that is basically just to recap on our algorithms and recap on the stop and watch tool and how we're monitoring and how to escalate them. But this is just some feedback that we got from staff, and it's been really, really positive. So, it's making them feel confident, and they certainly do see the value in the tool. So you see things like what would we have done if we had not had stop and watch when COVID came, or the tool is very useful to look out for changes that might be linked to COVID-19. They're just some of the feedback, but to be honest, all the feedback has been very positive. So that's been fantastic. So I suppose with everything there comes challenges. I suppose if we were to look back and see the journey that we had with this tool, we'd certainly say it wasn't the way we were going to implement it. But they're again having access to being able to provide training 3 times a day probably wouldn't have been in the run either. So it's a very unusual journey, I suppose. But I suppose what we are seeing is people still have a bit of confusion around the stop and watch with clinical observations, and I think that's okay. I think once people are aware of the monitoring that we're doing and to report that that's okay, and we'll keep working on that from this side of things in the training as well. The assurance regarding the accuracy of baseline information, that's difficult, as Ailish was saying. So that is difficult for us sometimes to support our service users with that, with the accuracy, we're finding the accuracy of baseline information. Ensuring consistent application of the tool, that's something that we need to work on from a local level. To continue to provide training, as we know, that's very, very difficult, but we are doing that at the minute. And then I suppose the tool is more effective with frontline staff. That is definitely the case, but it's still, if you look at the signs that are relating to deterioration, I think staff that aren't that familiar with it certainly pick up on some of those changes as well. So it certainly does have benefits in that. So I suppose, what would our plan be for this tool? So I suppose it's to continue to liaise with say, HSE and developers to further progress this tool in intellectual disability services. And I suppose it would be fantastic to have our own Irish-based tool. I suppose would be really, really good, you know, for intellectual disability services. Within Sheaverstown, we're going to continue to use it as part of our monitoring toolkit for the recognition of COVID-19, and with the current emphasis on rolling out the phase 2 training. We're going to use the tool for specific research on individuals and groups like we had, I suppose, the idea pre-COVID, to inform future support needs and then validate its effectiveness. That would be really interesting. And to provide stop and watch training to all new employees as part of the induction programme would be really, really useful. And then we would love to see this to extend the education on the tool to service users and their families, because it's such an easy tool to use. So what I'm going to do is now I'm going to hand you back to Eilish, and she's just going to continue and finish off, I suppose, the presentation with just other Irish developments in relation to the tool.
Sorry, Eilish. All right, take your time. Sorry, everybody has to bring their own chair with them because, you know, you can't share chairs because of COVID and all of those joys. So I just want to talk a little bit about another project that actually we just kind of in the last couple of weeks really gotten in touch with the Nursing and Midwifery Planning and Development Unit, so the NDPU, who happened to kind of co-develop a very similar plan to what Sheaverstown ended up doing during the COVID-19 process, but in care of the elderly. So they're actually in the process of liaising with the American-based developers of this tool to look at implementing it in terms of care of the elderly across Ireland. So they're based in Dublin, Mid-Leinster, but what they've done already is they've actually done a literature review on kind of best evidence and recommendations in terms of recognising signs of deterioration in the elderly population. They've done a needs analysis of the older person residential services. And then they've developed their version of what we have, which is the Interact program. And the Interact program uses the US Stop and Watch tool, which is very similar to the North Cumbria one. It's developed from the same tool, but the North Cumbria one looked at doing it specifically for people with ID, and they added the emojis and the easy use element of it. But their Interact program, you can have a look at the Pathways website, have a look at it if you want more information. And they've also done 2 pilots as well that they introduced the Stop and Watch tool in addition to assessment frameworks for nurses and the ISAR as well. So it's just really interesting that they developed at the same time in 2 completely different services without interacting with each other, and yet the pathway seems to have been quite similar across both services. And then just they're in the process of developing this Interact-derived product toolkit, which they are not quite finished with, but they are putting in place a licensing agreement with the American company developers of the tool to roll it out across Ireland. So that's just for more information to contact them. We would really hope to link in with them in terms of furthering the implementation of this process within intellectual disability services. So I know their focus is primarily on care of the elderly. And I suppose in disability services, we find that there's a significantly ageing population in intellectual disability services, in particular the residential side of it. And that's really across Ireland. That kind of traditional model of residential service provision has resulted in kind of people aging kind of almost what feels like all at the one time that they're passing that threshold. But I suppose for disability services, ageing would often be kind of start at 50 would be our care. The elderly would go from 50 onwards. So I know within Sheaverstown, part of our strategic plan and strategic development plan is to look at our ageing population. So we really hope to continue to link in with those services and continue to develop the tool. There's a couple of references there just for your information, but we're happy to answer any questions if anybody has any.
Thank you, Sandra, and thank you, Ailish. Can I just check, there's some questions coming through just into the chat box. Just one question around the tool being part of the iNews early warning system. Is it part of that, Sandra or Eilish?
So basically, I suppose our monitoring and escalation tool is comprised of stop and watch, and then, as I said, our own assessment tool, which is an adaptive form of the iNews as well.
Oh, very good.
So they're in conjunction together, which form the monitoring tools this year. Yeah.
Fantastic. And there's another question around, did you have to engage in a license agreement to use the tools, or are they freely available?
Well, I suppose we contacted North Cumbria ourselves, and they gave us permission and access for Cheeverstown to use the tool here. So that's how our access to the tool was, yeah.
But it was free. They gave free access for the tool to be used. I'm not sure if you were using it in more than one organisation, whether you'd need a larger licence for something like that. But the contact details are in the presentation as well, so you'll be able to have a look at the developer's information.
Thanks for that. And there's a question around what observation chart is used?
Okay, so if you see in the back of the toolkit, or the little booklet, there is a little guide there. But we have a paper tool that we use, which is modified by North Cumbria. And I suppose that you might have seen it in one of the slides. It's actually modified from the Interact tool. So that's the paper tool that would be used locally then in all the homes. Yeah.
Very good. And then there's also a question around what was your approach to gathering feedback from people, either service users or family members or staff around this innovation? How did you get your feedback?
I suppose, as you can imagine, we're still really very much in early days of this, and so as I said earlier on, we're doing our phase 2 COVID training, and really we looked for feedback after that training. So to date, I think we nearly have 300 staff trained up in that. The training happens every day at 11 o'clock, Monday, Tuesday, Wednesday, Thursday, Friday. So we're getting a lot of staff feedback from that. And so we haven't really been able to gather any feedback from service users or family at this stage. So it's very much just from staff. And as I said in the presentation, feedback has been really, really very positive. Yeah.
And I suppose just to add on to that, the original plan around implementing Stop and Watch came with a research proposal about exactly what we were going to look at and how we were going to gather data. And we were in the early stages of planning that when COVID hit. So we ended up introducing the tool way before we designed how we were actually going to research it. So we're kind of retrospectively researching now, and we're gathering qualitative information. We would have much preferred to have it planned and organised in terms of our data collection, but the reality is the importance of actually recognising deterioration superseded our research needs. So the retrospective data collection has been challenging, but so far all of the research is quite good. And one of the additional benefits of our COVID outbreak meetings is we have actual statistics of when Stop and Watch was recorded, when was somebody referred to the GP, when were they tested for COVID, what was their outcome. So hopefully when things settle down a little bit and we're no longer in firefighting stage, we're going to be able to analyse some of that quantitative data as well.
Right. Thank you. And I have another question around what kind of form is completed with Stop and Watch, or is there a form completed by staff members?
Yeah, it's actually, it's probably here in the presentation, and actually it's the paper tool that I was just speaking of there a few minutes ago. So basically, and Ailish is just going to bring it back to it now. So it's an adapted form of this tool that we would have received from North Cumbria. So you can see it on the left-hand side there, they were early warning tools. So basically what happens is if a staff is working with and supporting somebody, they notice the change, they basically circle the letter that actually identifies what that change is, and then they report that. And that tool then is kept in an area that's right beside our safety pauses on our houses. And obviously then the monitoring starts of that person in relation to that tool, and it continues until such a time, that obviously that the changes are and obviously the person is reviewed. So ideally, ideally that tool is used for 3 days. But within the context of COVID, we can't actually have that review to stop after 3 days. So that's when that tool will be closed, ideally outside of COVID, after 3 days.
Okay. Very good. And I have a question just around, has it been used by family members or just staff within the service?
No, it's actually it's only really been used by staff at the minute. We've been, I suppose, really trying to get the message to staff, first of all, obviously because of the time that we're in. But ideally, we could see it being a tool that could be really used for especially family members as well. And also we have service users who live independently and they live with other people as well. So it would be really good to communicate that to them as well, because I think it's a tool that they could use as well, which would be really helpful. So we would really love to extend that work out there out to everybody. Yeah,
absolutely. Great. Another question around, are there any issues with over-reporting or under-reporting? Did you come across anything like that?
Not over anyway.
No, not really. No, not really. As I said to you, when we would have received the information from frontline staff to bring to our outbreak meetings, every, would say, symptom or sign that was mentioned for a service user, it did have an action after it. So it's definitely not. No, it seems to be used appropriate at this stage of the game and what we can see. Yeah.
And can I ask you, how did you manage it as a project? Did you set up a working group or a steering group, or how did you manage it as a project?
You're kind of seeing the working group here in the room. So, I mean, Sandra was really the spearheaded project. She's the one who really pushed it forward. You can see her passion when she's talking about it. So she badgered us all into getting involved, probably in January sometime. Yeah. And as I said, the original plan was that we were going to look at it in terms of identifying specific signs of deterioration. So we were looking at kind of early dementia diagnosis and aspiration, and there was lots of things on the card in terms of our initial group. And then the COVID task force got set up in the early stages of COVID, and they adopted the tool and pushed it on that way. So I suppose our steering group in terms of the research kind of split at that point in terms of COVID detection versus the steering group for the original project. But I think now that things are starting to settle, things are kind of starting to fall back into place as well.
Very good. If an organisation or a service was to start this as an initiative within their own service, is there any advice you'd give them with regard to starting out? Anything that you maybe wouldn't do the second time around, or any advice or tips maybe for services who might want to start something like this?
I would say, as Sandra said earlier, one of the big things was the fact that we were able to roll out training 3 times a day, 7 days a week at the start. So I would put a huge emphasis in training in the early days, and that comes from kind of an organisational perspective and changing an organisational culture, essentially, at identifying signs of deterioration. You're asking for your staff to take on a whole new way of thinking and a whole new way of reporting. So I would put a very heavy emphasis on early training, and I think having management support, so having top-down support was really invaluable in the early stages.
Yeah. I think that's where I suppose the whole process is a real team effort. So it's not really just one person or everybody in this room. It was really the whole organisation, and there was support everywhere for this. So that was really, really helpful. People really wanted it. Yeah.
And you talked about aligning tools, so aligning other processes within your organisation. That seemed to be really critically, was a success, I suppose, for the initiative, just being able to align it.
Absolutely. And I suppose, so as I said, at the initial stages, it was very overwhelming for staff as well. So that's why we're going back again. So, we realised that we need to keep going with this, because it wasn't probably a natural journey for the tool and such. So we're doing the training, and we're finding actually the phase 2 is really being effective actually in supporting staff really, and with the use of the tool.
Very good. And can I ask you, Alan, is this a typical project that comes through the Spark programme? Is this a typical initiative that would come through?
Just first of all, say a great presentation, guys. It was extremely interesting. I think the thing that makes it atypical was that a lot of people come in with great work ethic, but seeing how hard they've worked throughout it has kind of singled them out for being a very, very strong project. The support that they get on the day, the workshops are brilliant. I think a lot of people would see the value in kind of, it brings people to thinking. I think how Sandra was thinking even before she came to us, that puts the user at the complete center of everything. And what they've done here, I think is given the staff working in their center the ability to voice the concerns that they see. So I think it's brilliant. Yeah.
Right, yeah, absolutely. And I just have one other comment around the tool, and they're saying that you outline possible confusion with vital sign observations, and it might be worth exploring a branding exercise to reduce this confusion. I don't know if you have any comments on that.
I don't think there's so much confusion with the vital signs, but the purpose of the tool is to identify signs of deterioration before they show up in vital signs. So the idea is that the person is placed under monitoring before there's a change in vital signs. So what we were noticing, in particular in the early stages of COVID, was that maybe somebody seemed out of sorts and they showed up on stop and watch 3 or 4 days before their temperature changed. So their vital, I suppose the stop and watch tool leads to an escalation in monitoring vital signs, which might lead to an escalation in terms of somebody's presentation. That might mean a GP referral or consultant referral or whatever that escalation is. So I think that the monitoring of vital signs is part and parcel of the overall toolkit, where stop and watch, the early identification signs, aren't as reliant on the vitals.
Yes, absolutely. And I think we're kind of doing a bit of work around that in our training at the minute. We're presenting scenarios, we say, of situations where, people may or may not have presented with COVID, but we're giving examples of both, of people who did present with stop and watch signs and no clinical signs, just for staff to be able to have time to reflect and go, to actually think, the difference between the two. Because I think just sometimes when we think of deterioration, then sometimes we just think of the clinical signs first of all before we kind of, look at those deterioration signs. So we're working on that, and I have to say scenarios have been really effective as well to help staff recognise that.
And can I ask you about the training and delivery side of things? How have you been delivering training? Is it face-to-face using presentation slides, or as you mentioned scenarios there? What kind of tools have you been using to deliver the training?
So obviously, due to, I suppose, we say obviously social distancing and things like that, we have to be very careful of the venues that we use. So ideally, actually, I think the most effective venues we're using is the smaller numbers where we maybe have 10 people. And we're showing the video again. We're looking at our algorithms again in relation to monitoring and escalating. And then we're looking at scenarios based on, real life situations that may have occurred during the time. And it just seems to be giving time for staff, because I suppose at the time in the early days, it was very much trying to get the message across. But it's given time for staff like that to ask questions and then also to give their feedback as well. So it's really worth doing at the minute, even though it's very time consuming. It is really worthwhile doing. We're finding it very effective.
Very good. And what's next then for Cheeverstown in relation to this initiative, or even any other future plans? Anything you'd like to share with us?
Thanks. I suppose we're back to the drawing board in terms of looking at how we are going to research some of the tool. So we're in a different scenario now because the tool is already implemented. It's already existing in the service. So a bit of a redesign cap going on in terms of how we are going to research the efficacy of the tool, and then really hoping to liaise with the developers of the tool and the HSE service that we just mentioned there in terms of progressing a tool like this within disability services. So that's really where we are at the moment. It's back to the drawing board and back to kind of planning in terms of how that's going to happen.
Thanks very much for that. And Alan, from your side, what's next for the Spark programme? You've obviously received in some expressions of interest around COVID initiatives. So what should we be seeing maybe early next year in relation to Spark?
Hey, thanks, yeah. So there's a huge amount going on. With the COVID call, we got a massive response from all different sorts of workers in the health system. And I suppose there's such a varied amount or a varied array of projects that come in. We get projects similar to this, which are fit quite well into quality improvement, to the spectrum going towards people thinking of surgical devices and things like that. So we always do workshops, and that's what's happening next. So the first set of successful applicants are going to attend the workshop for the COVID call at the end of this month. And then from there, we're hoping to get more designers and things involved in it and hopefully push through to get COVID solutions out quickly, because I know a lot of the things that have come in relate to frontline workers and lots of fatigue and people who are facing difficult situations. So we're driving through and concentrating on getting solutions as quick as possible out there. And then early next year, each year we run the Spark Ignite in association with the HIH, and that'll be advertised, I think, soon enough, actually. So I think people will start getting emails about that. And if you're interested, we're always very excited to hear from more projects too. So, and thanks again for the opportunity to talk.
That's great. Thank you, Alan. So I'm just conscious of the time now. So thank you, all of you, for a very interesting presentation. And it's a great initiative, and I hope other services will be in contact with regard to implementing within their own areas. So thanks very much for sharing with us your initiative. And if you're looking for any information with regard to this topic, and also with regard to the Spark program, I know Naomi is going to add in some links to the presentation, and we'll share it then up on the HSE website. So thanks so much, and thanks for everybody for participating today. It's great to see so many of you contributing. So just maybe Naomi will just highlight, I suppose, what's coming up next with regard to QI Talk Time. And our next QI Talk Time will be the 1st of December, and we'll be hosting Caoimhe Gleeson from the from the Assisted Decision Making Office and the HSE National Office for Human Rights. And we also have two other speakers, Professor O'Keefe and Professor O'Shea, and the topic for that is around DNRs and decision making during a COVID pandemic. So that's the 1st of December. And I'm just asking everybody who's still on there, if you have any ideas for future QI Talk Times, please come and contact us, because we will be planning out QI Talk Times for next year. So thanks to everybody, thanks to our panelists, and thanks to everybody who participated, and have a great day. Okay.
Thanks very much. Thank you.
Bye.